This will be week 4's presentation dealing with complex care related to respiratory function, discussing acute respiratory failure, ARDS, and also patients who need to be mechanically ventilated. So some of the diseases and the conditions that can cause oxygen failure, respiratory failure, we're looking at increased altitude, smoke inhalation, carbon dioxide poisoning, and also we have the disease processes, pneumonia, CHF, once again, pulmonary embolism and ARDS. You notice those are common in both of the respiratory failures. Also, a decreased hemoglobin can be a cause of the oxygenation failure. When we're looking at a patient who has combined respiratory failure, meaning they have a ventilatory as well as an oxygenation issue, we're looking at the patients who have abnormal lungs. They have abnormal lung function related to a disease process. Our patients who have chronic bronchitis, emphysema, cystic fibrosis, some patients who might have some cardiac failure in addition to the pulmonary component. When we're looking at the diagnosis of ARDS or acute respiratory distress syndrome, we're looking at a patient who has an acute lung injury. Sometimes it can be associated with a patient who has TRALI, and we're going to talk about TRALI in just a little while, transfusion-related acute lung injury related to blood transfusions. But ARDS is a type of respiratory failure in which the lungs stiffen and they don't make surfactant. A patient with ARDS is going to have hypoxemia despite 100% oxygen. So it's refractory hypoxemia. Normally when our patients are hypoxic, we go ahead and give them supplemental oxygen and we see a rise in their PO2 or oxygen saturation. So when we're seeing that and we're giving the patient 100% oxygen on a non-rebreather, and oftentimes their hypoxemia will not improve or sometimes it'll even get worse. With ARDS, they have a decreased pulmonary compliance. Your patient is going to be very short of breath. When we're looking at a chest x-ray on someone who has ARDS, we're going to see a bilateral pulmonary edema. They're also going to see very dense infiltrates. And when they talk about dense infiltrates, they will use descriptive words like ground glass appearance. Basically, what you're going to see is you're going to see a whiting out of the normal chest silhouette. This is an x-ray of a person who is in ARDS. So if you're looking at the screen and you're seeing the x-ray on the left side, that is a normal chest x-ray of the cardiac silhouette as well as the lungs. We don't have anything going on there. That would be considered an unremarkable or a normal chest x-ray. When we're looking at the chest x-ray on the right, that is a chest x-ray of someone who is in ARDS or does have ARDS at this point. As you can see, the lung areas very whited out, very edematous inside, hence the pulmonary edema. We can still kind of see a cardiac silhouette and such, but as far as the lungs, obviously abnormal. And when you're looking at it, you might say, oh, it's a bad x-ray or something, but that's what you're going to see. You're not really going to be able to see those structures anymore. Basically, you're going to see more of a white appearance. When we're looking at patients who have ARDS, it's caused by a systemic inflammatory response, an inflammatory response to a patient who has become septic, patients who have suffered burns or smoke inhalation. Pancreatitis can cause an inflammatory response in the lungs that can turn into ARDS. Anyone who's had any trauma, and transfusion. When we're looking at transfusion, as I mentioned before, a transfusion reaction can cause a patient to go into ARDS. For our patients who are having any kind of respiratory failure or respiratory issues, one of the things that we do have to do for them is we have to intubate them and mechanically ventilate them. If you have a patient who is going into respiratory failure, who is having difficulty or perhaps not responding to oxygen supplementation because they are in ARDS or because they're in a severe respiratory failure, we do have to make sure that they're going to be intubated. If your patient's going to be intubated, you need to make sure that you notify, obviously, the doctor who's going to do the intubation and also the respiratory therapist. Prior to the intubation, we're going to provide oxygen, 100% non-rebreather. Hopefully that will work. If it's not going to work, we may need to go a step higher, go to that bag valve mask to actually assist in the ventilations. When we have the intubation tray, that comes sometimes on the crash cart, or it can come separately if your unit does carry it that way. One of the things that you're going to do is make sure that all your supplies are there for the doctor. You're going to make sure that you have the ET tubes. You're going to make sure that you have the laryngoscope. When they have the laryngoscope, one of the things that you do need to do is make sure that you connect the blade, make sure that the light is working for the doctor. So the blade and the actual laryngoscope are going to come apart. Two different blades that we're looking at. We're looking at a Miller blade or a Macintosh blade. Miller blade is going to be a straight blade. Macintosh is going to be a curved blade. It's the doctor's preference a lot of times as far as what he's going to use on the patient. When we're looking at medications, when it comes time to that, a lot of times we're going to give two different medications. We're going to give a medication that's a sedative for the patient as well as a paralytic. Oftentimes we're going to give that sedative first and then the paralytic. Remember, once we administer that paralytic, that's going to stop that respiratory drive completely. So once the paralytic is on board, we have to make sure that that intubation is going to happen pretty quickly. So we're not going to give these medications and then say, oh, where's the doctor? We're not going to do it. We're going to make sure that doctor's there. The doctor's going to know that we gave it. Once we gave it, it's going to move pretty fast from them. One of the most common sedatives that we're using in the hospital setting now is an etomidate. Paralytics, succinylcholine, rocuronium. The doctor oftentimes will give your dosages. He'll call it out. When you are positioning your patient and the bed, we need to make sure that the bed is completely flat. The doctor is going to be at the head of the bed. No pillow under the patient. You're going to take that pillow out of the patient. When the doctor is doing intubation, some doctors, if it's difficult to visualize the cords because the ET tube has to go through the cords, and for the best intubation, the doctor has to be able to visualize the cords. Sometimes you'll be asked to apply cricoid pressure. It's not something that we commonly do anymore, but I still see it occasionally where they can't see, they don't necessarily prepare for a difficult intubation with tools that they might need. So we'll give them a little bit of cricoid pressure on the outside of the cricoid cartilage. And by just gently pressing down on that, what it does is it makes it so they can visualize the cords a little bit better. And as long as the ET tube is passed through those cords, they know that they're in the right place because they're definitely going into the trachea. When we're looking at endotracheal tubes, there's a couple different kinds that you can give and that the doctor may ask for. When we're looking at endotracheal tubes, they come in different sizes. The sizes will be depending on a guesstimate on what the patient would need, where we're going to get into the right place. Cuffed versus uncuffed. When we're looking at a cuffed endotracheal tube, that's what we're looking at on the screen. A cuffed endotracheal tube will have a balloon in it. That balloon is then inflated. A couple different things that occur. It helps to keep the ET tube definitely in place. It also helps to prevent gastric secretions from going down in the trachea. If we have an uncuffed tube, we don't have anything blocking that extra area. Once your patient has a paralytic and they're going to be intubated, remember once they're intubated, one of the things that we do have to do is check placement for the ET tube. A couple different ways that placement is checked. We do check for auscultation of that ET tube. That's one of the first things that they do. So we listen over the epigastric area and we're listening for air over there. Then we listen onto both lung fields, right and left. Make sure that when we do hear it, we're hearing equal breath sounds on both sides. If we don't hear equal breath sounds, we hear more breath sounds on the right. We may have an ET tube that's actually placed too far down and gone into a right mainstem bronchus intubation. And in that case, yes, we're in the right place, we're in the lungs, but we need the lungs to be given air and ventilated equally. So the doctor oftentimes then will pull back the ET tube. One of the things after intubation that the doctor will tell you and that you as a nurse need to make sure you have documented is going to be the size of the ET tube and where it is taped at the lip line. So it'll give you a centimeter, 24 centimeters of the lip line or 21 centimeters of the lip line. That's something that we document, and basically that's our starting point. So if you were to come back and do an assessment later and the number was greater or smaller, we're concerned that either it's been dislodged and not in the proper place, or that possibly it's been pushed further down into the bronchus. The ET tube then needs to be secured. A lot of times when we're doing this, I can tell you 9 times out of 10, your respiratory therapist is going to deal with that. They're going to deal with not only the inflating of the cuff, but also taping down or securing the ET tube. It can be secured with tape. A lot of times that's more of a temporary type securement. We also have devices and locks that they will use that are more padded for more of a long-term securement of that device. Remember, once they're paralyzed, we do have to breathe for them. So then that is when rescue breathing would come into play, and then we would attach them to the ventilator rather quickly. So a lot of times, if they get intubated and it's not a planned intubation, it's something that happens a kind of spur of the moment or in an emergency situation, sometimes RT will respond. They won't necessarily have their ventilators there. They might be down the hall or in another part of the area. So you would have to bag the patient then until the respiratory therapist comes. Oftentimes the respiratory therapist will go ahead and set up that ventilator, set up based on what the doctor recommends as far as tidal volume and thing, and we're going to go over those vent settings in a few minutes also. Different types of ventilators that we can have. A pressure cycled ventilator, basically that is going to push air into the lungs until a preset airway pressure is reached. So when we're looking at that and it's going to go, we're going to go, okay, so certain pressures reached, and we're going to do that. We're talking about time cycle. That happens when a machine itself pushes that air into the lungs for a certain amount of time. So it would push air into the lungs. Maybe the breath would be 15 seconds long. Once that 15 seconds long, that's when the breath stops. Volume cycled, that's the one we want to circle, we want to highlight. That's the one we see most of the time. Pushes that air into the lungs until a preset volume is delivered. So we set that on the tidal volume. So it may get 12 breaths per minute, but each breath is going to be 500 mLs or 750 mLs or whatever is decided for that patient. So we see that most often in the acute care setting. Some of our patients that are very sick or they need ongoing monitoring, there is a ventilator that has a microprocessor in it, and it has a computer inside of it. And when we're looking at that computer inside of it, it's that ongoing monitoring, and we can make adjustments depending on what's going on with that individual patient. When we're looking at the various modes of ventilation for a patient who's being ventilated, one of the modes that can be used is assist control. Assist control is basically a resting mode. It takes over the breathing of the patient. There is a preset tidal volume regardless of the inspiratory effort by the patient. One of the problems with this can be if the patient starts breathing their own and starts having more spontaneous breaths, we risk possible hyperventilation and some respiratory alkalosis with that. Another mode of ventilation refers to SIMV, or synchronized intermittent mandatory ventilation. It allows the patient to have spontaneous breaths, it coordinates with the patient's breathing, and it delivers the tidal volume with the pressure support. When we're looking at BiPAP, BiPAP is non-invasive pressure support. So when we're looking at a patient who's on BiPAP, they can be on BiPAP with a mask. I've seen it done with a nasal cannula. There is a different pressure for inhale and exhale. So with BiPAP, it actually notices oftentimes that the patient is breathing, and when the patient goes to take in a breath, there'll be a pressure that actually forces the air into the patient's lungs, and then when the patient exhales, it actually draws it out. Some patients do really, really well with the BiPAP. Other patients can't really tolerate the BiPAP. It really depends on the patient. When looking at the controls and the settings on all of our ventilators, there are a couple of different things that we need to look at. Tidal volume. Usually our tidal volume and average is 7 to 10 milliliters per kilogram of your patient. So when we're looking at a patient maybe who is 100 kilograms, 700, 750, we're going to see those type of tidal volumes. When we're looking at the rate is usually set 10 to 14. When we're looking at FiO2, we're looking at 21 to 100%. So that's the fraction of oxygenation that the patient is getting. Whenever we have the FiO2 and the air that's going into our patient, Remember that we have it heated as well as humidified when it goes through the ventilator because we're bypassing all of the normal parts of the respiratory tract. When we're looking at PIP or peak airway inspiratory pressure, that's the highest pressure that's going to go in during inspiration. We look at the PIP. I can tell you when you get your vent settings, a lot of times we're not actually even going to report or necessarily worry about that PIP. It's not something that they normally are going to give you in report, but just know that that is a pressure alarm that's setting on the ventilator. So if we have increased pressure, a lot of times the things that we need to do for our patients, suctioning our patient, checking to see if there's a kink in the tubing, because if the pressure's up, that means that something is inhibiting that air from going into the patient. When we look at the patient who has a CPAP monitor, we're looking at CPAP between 5 and 15 centimeters of water is the thing. CPAP can help with weaning, and what happens with CPAP is we don't have any pre-scheduled ventilatory breathing. The patient is actually starting to breathe on their own. So we use this when we're weaning our patient. Maybe we're trying to get them off the ventilator. They are having respiratory breaths on their own, but they need that extra pressure to actually get that air in and out in the beginning. So oftentimes we would bring it down and down further, called weaning them off until the patient's able to breathe on their own. When we're looking at a patient who has PEEP, we're looking at positive and expiratory pressure, 5 to 15 centimeters of water. PEEP is basically the amount of pressure that's left in the lungs after we exhale. Normally, when we exhale, we do have some pressure left in our lungs. We don't breathe out all of our air, and that's what the PEEP does. It keeps those alveoli open, prevents that atelectasis, allows that oxygen CO2 to actually go across those membranes. So they need that. When we're looking at flow rate, we're looking at the amount of oxygen. Oftentimes 40 liters per minute is the rate in which the oxygen is going to go into the vent. Some of the complications that we can have with our patients who are mechanically ventilated, we're looking at some different things that could occur for them when they're mechanically ventilated that we definitely have to watch out for. We have to watch out for hypotension, fluid excess. Reason for that is with the hypotension, remember we have a decrease in that blood flow, and then we have the renin-angiotensin-aldosterone system is kicked in, and the kidneys actually retain and hold on to that fluid. Some of the other things that could occur, we could have some barotrauma or some volutrauma, which is damage related to the fact of the amount of air that's going in. Too much of a tidal volume, too much pressure going in, or too much pressure going to one side versus the other. We also have to be concerned about damage to the alveoli and the fact that we can have shearing damage occur down at the alveolar level related to the closing and the opening of the alveoli. We also have some things that are referred to as ventilator-acquired lung injury or ventilator-induced lung injury, where we have a loss of that surfactant, fluid leakage, non-cardiac related pulmonary edema. All of these things can be complications when we're looking at it. When we're looking at the valley and the villi or the acquired or the induced lung injury, those are our patients that have these lung injuries. Sometimes we can't often get them off the ventilator. They're going to be long-term on that ventilator. Some of your ventilator alarms. Your ventilator alarms will go off because of Joint Commission and regulatory things. They have to be on and audible. We have to know when something is going on. A lot of times when we're looking at it, some of the biggest things that will go off are your high pressure alarms. When you're looking at your high pressure alarms, that's basically telling us that something is causing the amount of air that's going in to be blocked. So it's causing the amount of air that's going in, the pressure that it's pushing against is higher than it should be. Some of the things that we can look at are kinked tubing. Sometimes they can get kinked by moving them around, various different things. If your patient is coughing, or if they are bearing down and they're fighting the vent, increased secretions, or if they're biting down on the tube, those can all be things that we can do. Obviously, If they have increased secretions or something like that, we may need to go ahead and suction them, and that may solve our high pressure tubing. If it's kinked, obviously we're going to look at that tubing and make sure it's out. If they're biting it, we're going to do that. Low pressure alarms is a deflated balloon cuff sometimes, or that the vent itself is disconnected. One of the things that we do need to know as nurses is we need to look and fix for the possible causes. Remember, we're there to care for our patients. So yes, our alarms are going off and the vent is going off. When you enter the room and your vent is going off, you don't want to go right to your vent. You want to check your patient, right? So you may be having that pressure going off for something else. Maybe the vent is completely occluded and your patient is no longer perfusing, right? At that point, are we going to worry about anything going on? No, we're going to disconnect the ventilator and we're going to manually bag valve mask your patient. It's nice to fall back, and a lot of times the nurses will say, oh, that alarm's going off. Let's just call respiratory, which is great. Respiratory, that's their thing. They can come in, they can look at your thing. Remember, respiratory is not standing right outside your patient's room. So unfortunately, if the alarm's going off, yeah, you have to go in and assess your patient. If you've gone in and assessed your patient, you've done what you can do. Maybe you've suctioned the patient, you've checked for kink tubing, you've checked to make sure the patient's not restless and fighting the vent or biting the tubing, and you can't fix it, your patient looks good, oxygenation's still good, yeah, then you can wait around for respiratory. But you want to make sure that you try to troubleshoot before they get there. When we're looking at troubleshooting our vents, remember I said as the alarm's going off and we can't figure out what's going on, you're first going to assess your patient, right? See if there's something going on. Is your patient not oxygenating well? Is your patient restless? Are they possibly in pain? A lot of different things. So you're going to treat your patient first. Obviously, if they're not oxygenating, you've got to do what you're going to do to oxygenate them. Some of the acronyms that we use to troubleshoot our vents is DOPE, right? You're going to check a displacement of the tube. How are you going to check for displacement of the tube? You're going to listen to your lung sounds, right? You should hear that same lung sound, right? Equal bilateral breath sounds. If the tube is still in the place, check the centimeters, right? You have the numbers at where it's supposed to be taped at the lip line. It should be in that exact same place. A lot of times when we have displacement of the tubes can displace by moving our patient. If our patient is too restless, maybe our patient got a hold of that tube, right? And they can pull it out themselves and exit. Obstruction of the tube. When we're looking at obstruction of the tube, it could be from secretions. It could be from a kinking of the tube. Pneumothorax. Pneumothorax can have some of the trauma that we can have. We talked about the trauma from the pressure that we could have. Pneumothorax could be one of them, right? We could have a ventilator-induced pneumothorax, and then when we listen to the lung sounds, we are not going to hear lung sounds on one side, right? When we don't hear those lung sounds on one side, there's a couple different things. Perhaps the tube got displaced down the other bronchus. But when we take an x-ray, we can see the pneumothorax definitely there. But if we have a pneumothorax, our patient very well might not be ventilating appropriately. So we want to make sure that we can fix that. And the E has equipment. Ventilators are like any machine and they can fail, right? If you ever have an issue where you think it's the equipment failure, like I said, you disconnect your patient and you provide ventilations via bag valve mask. A lot of times what they'll do at that point is just switch out the ventilator. But there's a lot of troubleshooting that we go to before that. I can tell you most of the time when I have patients whose alarms are going off, the two number one causes are going to be some obstruction. Usually they need to be suctioned, or the patient is anxious, restless, or biting on their tube. Oftentimes, you might hear nurses say that they're bucking the vent, which means they're fighting the vent breathing for them. If that's the case, usually what your patient needs is they need more sedation. Once they have more sedation and they're relaxed and they're not fighting the vent, then the vent can breathe for them. So we talked a little bit about the complications. I got a little ahead of the game there. That hypotension and fluid retention, I talked about that decreased blood flow to the kidneys because of the hypotension, and you have the RAS going into place. The barotrauma from pressure, volume trauma from more pressure in one lung, excessive volume in one lung versus the other, Atelectotrauma, that's the damage to the alveoli. Biotrauma, when we're looking at biotrauma, we have inflammation in the alveoli itself, and then we have the valley and the villi, as I talked about. We also have possible acid-base imbalances. Remember, we're taking over the respiratory component, and one of the big components of acid-base is our CO2. So if we start messing with that CO2, we can have an acid-base imbalance. One of the nice things about the ventilator is we can very easily fix acid-base imbalances if that is caused by the ventilatory effort. Some of the other things that we need to look at in other parts of the body, our GI ulcers are very, very common on our patients who are ventilated. So our patients who are ventilated, of course, they're NPO. They will be getting sometimes early on feedings, sometimes through an NG tube. Sometimes we have TPN. Our patients who are ventilated are always going to need an NG tube, and that has to do with reducing the amount of air that's in the stomach, oftentimes from intubation attempts. And we also want to prevent their vomiting, because yes, if it's cuffed ET tube, it does protect it somewhat, but gastric secretions can still get down there, and we can have a issue where we have an aspiration pneumonia. They also oftentimes have reduced nutrition because of being on the ventilator. Infections are common. A big thing that we have to worry about in the hospitals are ventilator-acquired pneumonias. Some of the other things that can occur body system-wise, muscle deconditioning and weakness. Oftentimes our patients who are ventilated, they will lay in their back, they will lay in bed for long periods of time, and they will have a weakening or an atrophy of the muscles. We also can have our patients who become ventilatory dependent, inability to wean. A lot of times our elderly patients or people who have chronic lung issues, they are more difficult. So they'll be on the ventilator, the longer time they're on the ventilator or any kind of comorbidity, their lungs kind of get used to the fact that the ventilator is doing all the ventilatory process. So when we do try to take them off and try to wean them off, a lot of times we can't always wean them off. Our patients have ET tubes for short periods of time while they're in the hospital. If it's going to be a long term or they can't wean them off, oftentimes they're going to go ahead and go for a trach. So they're going to put in a tracheostomy and they're going to ventilate that patient through a tracheostomy tube. Patients who are ventilator dependent, they can't wean them off. They are going to be long term with those tracheostomies and they're going to be vent dependent. Because ventilator-acquired pneumonia is such a big issue, many hospitals have a VAT prevention bundle, and they pretty much contain the same things. When we're looking at the patient who is on a ventilator, we're going to get that head of bed for the patient at least at 30 degrees. Big oral care, right? A lot of organisms in the mouth area, in the oral region, and if we don't do that good oral care, even though they're on a ventilator, those organisms then travel down into the lung area and can create an issue. So we do make sure that we do good teeth brushing. Normally when we're looking at teeth brushing, they recommend it every shift, every 8 hours, something along those lines. Of course, we're going to brush those teeth. Your patient cannot swallow anything, so you're going to have to use that suction to go ahead and brush their teeth and suction out the fluid. Chlorhexidine rinse is the pretty much standard of care at this point. When we're looking at chlorhexidine rinse, a lot of facilities will do it Q2 hours for these patients oftentimes, sometimes Q4, Q8, but we're going to do that with a chlorhexidine rinse, and basically the chlorhexidine is going to kill away those organisms in there. Talked a little bit about it, ulcer prophylaxis comes in there. Also some facilities, along with that ulcer prophylaxis, not that it's necessarily part of the VAT bundle, but they'll stick it in there with the VAT bundle. They'll do a DVT prophylaxis also. So just know that you might also see that kind of roped into there. Aspiration prevention for our patients. When we're looking at that, the ulcer prophylaxis, prevent them from vomiting, prevent that aspiration. Pulmonary hygiene, right? We need to make sure that they're suctioned, and sometimes they will come in, patients on vent, they're not getting the they will do that pulmonary hygiene, the chest physiotherapy. Sometimes they will give them breathing treatments through their ET tubes, various different things like to prevent that pneumonia.